Infections acquired during healthcare delivery are a major problem for global health, causing harm to patients and putting the very notion of safe, trusted health systems at risk for all countries. 1 in 10 patients get an infection while receiving care. Infections cause up to 2/3 of deaths among hospital-born babies.
These are just a few shocking problems we are facing in our world. But healthcare-associated infections are avoidable, and to prevent these infections, including those antibiotic-resistant, is a key priority for WHO. This is why WHO has engaged experts and colleagues with field experience to resolve this problem. Also based on scientific evidence, we all together identified the core components that make IPC programs successful to prevent harm.
The new core components are absolutely essential for us to have for low resource settings because WHO documents carry a lot of clout with the ministries of health. It can prove to be cost effective, but most importantly the IPC focal people working in healthcare facilities find it a great support and it gives them the clout to do their job properly.
So infection control is really critical to the control of antibiotic resistance. You know, if you think about the spread of antibiotic resistance, it's just like a bushfire. And of course, yes, we need new fire trucks and new helicopters, that is new antibiotics, but they're 5 or 10 years away. And in the meantime, we need a fire break, and that fire break is good infection control. And so this is why the core components are so critical. Whether you're a wealthy country or a poor country, all countries need a national policy on infection control, and the core components are exactly what we need to direct that effort.
WHO recommendations identify 8 core components that make infection prevention and control effective and aim to support countries and health facilities to prevent healthcare-associated infections and antimicrobial resistance. The first component is about having an infection prevention and control program supported by a dedicated budget and trained staff.
Infection prevention control programs are essential in healthcare facility level because healthcare-associated infections lead to high cost and high mortality.
In order to ensure establishment of strong infection control programs, we need to make sure there is political commitment at the highest level, starting with resolution at the World Health Assembly, and then moving on to establishment of regional programs.
The second component is to have and implement guidelines on infection prevention and control standards and operating procedures.
For us, guidelines provide a standard that we can follow, we can all agree on. So now we have, like for example in Chile, the healthcare providers, the directors of the hospitals or the infection control programs use the guidelines in order to allocate resources or organize healthcare in order to make it safer for patients.
The third component is education and practical training based on infection prevention and control principles and best practices for healthcare workers, managers, and other professionals.
Education and training can change practice if we do 4 things. Number 1, if we contextualize within their experiences. 2, make it very practical. 3, have champions to drive the process. And 4, get the administrators involved by having a proper advocacy plan.
The fourth component is healthcare-associated infection surveillance and timely feedback of results, both at the national and facility level, to detect the problem and guide interventions.
So when hospitals do surveillance, they usually measure the burden of infections and describe the pathogens causing infections and the resistance pattern. Good quality surveillance data contributes to tailored prevention activities to reduce the burden of infections and resistance of organisms.
The fifth component is the use of multimodal strategies to implement recommendations to improve practices at the point of care.
These guidelines reinforce the value of multimodal strategies for decision makers, for leaders, for implementers. And what this means is making sure the right resources are in place, the infrastructure to support improvement. It means using the most effective methods of training and education. It means checking that the right thing is happening at the right time, monitoring and evaluation and feedback. It means communicating and advocating and campaigning for infection prevention, and all of this taking place within a culture that supports improvement in infection prevention and control. All countries and all health facilities can benefit using a multimodal approach to protect people.
The sixth component is regular monitoring of healthcare practices according to standards and guidelines, followed by timely feedback of the results, both at the national and facility level.
I think monitoring in the field of infection control is a very important issue And for instance, I would like to give you an example from my own country. We have established hand hygiene consumption as an indicator for good hand hygiene. And meanwhile, more than 1,000 hospitals in our country are using this indicator, and we were able to achieve a lot of increase in this field.
The seventh component is to make sure that bed occupancy does not exceed the standard capacity of the facility and that staffing levels are adequate according to patient workload.
Level of staff and bed occupancy. We have three major challenges to overcome. First is the lack of human resources on IPC. The second is the lack of the involvement of administration. And third, we have a lack of involvement of patients and families. So we have to address all these challenges if we want to overcome this problem.
Establishing a team at the national level provides guidance and leadership that could accelerate the momentum that is needed to ensure that IPC is implemented throughout the country.
The eighth component is to ensure that patient care activities are undertaken in a clean, hygienic environment with adequate infrastructures and equipment, in particular for hand hygiene.
Water and sanitation are absolutely fundamental to preventing infections. I think this is overlooked. We know it's overlooked. We did a global report where we understand that 40% of hospitals are without, a source of water, and that's unacceptable. We walk into these health facilities and we see unhygienic conditions, and we know diseases are going to be spread. So this is something that is absolutely wonderful that it's been included in these guidelines as a prerequisite.
The last public health emergencies of international concern that was declared by the WHO showed that how important is to have infection prevention and control in place for member states to fight epidemics and fight emergencies. If we are better prepared, if we have infection prevention control structure in place, we have a better chance to fight these emergencies.
One of the great lessons learned from outbreaks like Ebola and MERS and SARS is the importance of strong infection prevention and control from a global health perspective to prevent the next epidemic.
Effective infection prevention and control can lead to more than 30% reduction of healthcare-associated infections. However, implementing the recommended core components isn't always easy and takes time and commitment. But there are great examples around the world that this is possible, even with limited resources. Countries and healthcare facilities engaging to do this will reduce infections and antimicrobial resistance and will save money. Most importantly, this will make patients safer and save lives. Thank you for committing to infection prevention and control.
Infection control is an ongoing process that promotes effective methods of prevention and control of infection. Its mission to protect patients and visitors from acquiring infections while visiting our clinic and minimize healthcare worker exposure while providing patient care. An individual's risk for infection depends upon how they were exposed, the strength of the infectious agent, the type and amount of infectious agent to which they were exposed, and that person's susceptibility to infection. At United Family Medicine, employees in certain job categories may come into contact with blood or other potentially infectious material and are considered at risk. They include nursing, dental, laboratory, X-ray, and front desk. Advocates should be asked to contact patients who present a risk by phone, but those who also serve as interpreters are included here, along with providers whose services we contact from ELINA. OSHA's bloodborne pathogen standard recognizes that blood and body fluids contaminated with blood present risk for exposure to HIV, hepatitis B, and hepatitis C. But blood is not the only consideration. Other potentially infectious materials present risk for acquiring these infections. They include semen and vaginal secretions, amniotic fluid, fluids that provide cushion, support, and decrease friction from surrounding organs, unfixed human tissue and organs, including non-intact skin, and culture media, cells, or any body tissue known to contain either HIV or hepatitis B. While saliva is typically not included, it is considered a risk for exposure both in dentistry and in instances where there has been mouth trauma. OSHA instituted a set of required workplace practices, universal precautions to reduce exposure to these bloodborne pathogens. But OSHA's scope was limited. By considering only exposure to HIV and hepatitis B and C, a host of other pathogens encountered in our workplace went unaddressed. Standard precautions incorporates universal precautions and includes additional measures to prevent transmission from other sources. They include hand hygiene, safe injection practices, safe handling and decontamination of medical equipment and environmental surfaces, respiratory hygiene and cough etiquette, and use of personal protective equipment. Standard precautions are the minimum level of infection control precautions to be used for all patients and when handling potentially infectious materials at United Family Medicine. Hand hygiene is the single most important practice to reduce transmission of infection. Whether using alcohol-based hand rub or soap and water, proper hand hygiene covers all surfaces of the hands and fingers up onto the wrists. Alcohol-based hand rub is generally preferred to soap and water. To use alcohol-based hand rub effectively, apply a sufficient quantity to cover all surfaces when hands are rubbed together, so it takes 20 to 30 seconds to completely dry. Occasional soap and water wash should be used to remove emollient buildup. Under certain circumstances, soap and water is preferred. Soap and water should always be used when hands are visibly soiled. And because C. difficile forms alcohol-resistant spores, soap and water is also preferred when infectious diarrhea is present. Pathogens prevalent in the community at any given time may also call more appropriately for soap and water wash. United Family Medicine will monitor emerging disease information from the Minnesota Department of Health and CDC to keep you informed. For soap and water hand hygiene, wet hands with warm rather than hot water to prevent skin irritation. Add soap and rub together vigorously for no less than 15 seconds. Rinse thoroughly with fingers pointing down and dry with a disposable towel. Use the towel to turn off the faucet. Total duration from wetting hands through drying should take 40 to 60 seconds. Hand hygiene should be performed prior to and following any direct patient contact. Whenever hands become visibly soiled or contaminated, this includes coming into contact with blood or other potentially infectious agents, non-intact skin or mucous membranes, or contaminated equipment. Whenever gloves are removed, and when moving from one body site to another, gloves should be removed, hand hygiene performed, and new gloves applied. When entering a designated clean work area, this includes prior to preparing medications or procedure trays and prior to handling invasive devices. When entering or leaving the clinical work area, This includes arrival in the morning and prior to leaving for the day, and should always follow bathroom or lunch breaks. And prior to and after personal contact, including touching eyes, nose or mucous membranes, or when handling personal care items. Gloves should be worn when exposure to blood, body fluids, or other potentially hazardous material is anticipated. When there is direct contact with patient's eyes, nose, mouth, or other mucous membranes or non-intact skin, when invasive procedures are being performed or a body cavity is explored either manually or with an instrument, and gloves are a requirement at United Family Medicine when giving injections. Gloves are considered single-use and to be discarded into appropriate waste containers when removed. They should be changed when the integrity of glove material is compromised and are to be worn whenever caregivers have cuts on their hands or other breaks in the skin. They are to be removed from the wrist in a peeling fashion that turns them inside out to contain contaminated materials within. Personal protective equipment includes gowns, worn to prevent contamination of skin or clothing when a known or suspected infectious agent may be transmitted via direct contact, splash or spray, or exposure to airborne substances. Gown front and sleeves are considered contaminated. They should be removed in a peeling fashion, starting at the neck and shoulders, turning them inside out to contain contamination. During removal, contact should only be made with inner surfaces. Personal protective equipment includes masks. These are worn when a known or suspected infectious agent may be transmitted via exposure to respiratory secretions and when there's potential for splash or spray. They should also be worn when caregivers have a respiratory illness. Type of mask worn is based on exposure risk. For illnesses spread by droplet, standard surgical masks should be worn within 3 feet of patients when caregiver immunity has not been established. Small particulate N95 respirator masks are worn when pathogens may aerosolize into airborne particles small enough to be carried on air currents and capable of penetrating surgical masks. N95 masks are required for all cases of active or suspect tuberculosis. Latent cases are not infectious. N95 masks should also be worn for protection when measles and varicella is suspect and caregiver immunity has not been established. N95s may also be considered when there's potential for aerosolization of pathogens during certain procedures that create heavy splash or spray. Respirator masks are not one-size-fits-all. They require customized fit and seal checking for leaks with each use. Fit testing and training is offered twice yearly. It's a good idea to keep a mask in your work area. Backup stock is kept in the cupboards across the hall from advocate offices. All staff members are expected to participate in fit testing when provided and compensated if they attend in their time off. Staff members who've attended sessions but cannot be properly fit should exclude themselves from care of patients with airborne illness. Masks should be removed and replaced when visibly soiled or wet. The face piece should always be considered contaminated, and removal accomplished from ties or elastic furthest from it. Personal protective equipment includes protective eyewear. This is worn anytime there is potential for splash or spray of infectious material. United Family Medicine provides masks with attached eye shields, goggles, and face shields. The front of used eyewear, like masks, is considered contaminated. These also should be removed from the back. Reusable goggles should be decontaminated prior to reuse. In the event eyes are inadvertently contaminated, they should be flushed liberally with water. Eye wash stations are located in the lab, Yellow Team Soiled Utility Room, and in dentistry. Additional PPE is available on each team and includes head and shoe coverings. Guidance documents in place include strategies to prevent exposure. These include placing scheduling comments to alert staff of potential disease conditions, asking patients to mask on arrival, priority rooming, appropriate use of personal protective equipment, and good environmental cleaning practices which help to protect everyone. Recognizing risk and acting appropriately to prevent exposure is the basis for transmission-based precautions. It is a thoughtful process, and while guidance can be provided and policies written for infection control to be truly effective, communication is key. Scheduling notes, signs, and simple sharing of information between departments and individuals helps to prevent the spread of disease. Sharps include any item that can puncture, cut, or otherwise break the skin. Examples are needles, scalpels, lancets, and dental scalers and picks. Glassware and hard plastics that have broken, exposing sharp edges, are also considered sharps. Sharps are never reused, bent, recapped, or in any way manipulated by hand. Where present, sharp safety devices are to be engaged immediately following use. Two-handed needle recapping is expressly prohibited. Replacing needle caps may only be performed using a one-handed scoop. Sharps are to be discarded at their point of care in biohazard-labeled puncture and leak-proof containers that are stored in an upright position. Never reach into sharps containers and seal and discard them once they've reached fill lines. Avoid hand placement directly in the path of a needle when giving injections, and be sure to ask for help when needed to restrain children. Hands should never be used to handle broken glassware or hard plastics, even when wearing gloves. Pickups should be used, or borrow a broom and dustpan from the lab. And please let us know what you know. Provide suggestions to your manager or safety officer if you become aware of safer sharps options. Biological waste is regulated by federal, state, and local law. We have already discussed proper disposal of sharps. Regulated waste also includes liquid or semi-liquid blood or body fluids, and waste that may release contaminated material when handled. This includes saturated articles that may release material if compressed, and those caked with dried material that may flake when handled. It also includes live or attenuated human vaccines. Infectious cultures and equipment used to manipulate those cultures are also included. Biohazard labeling is required on all biological waste meeting criteria. When leakage can't be contained by primary containers, including red bags, it should go into secondary containers. These should be leak-proof, able to hold all contents, and be securely closed for transport, and display the biohazard symbol. Contact surfaces should always be disinfected between patient visits. Friction to physically remove visible soil or organic matter removes large numbers of microorganisms and should always precede disinfection. Protective underpads may be used to minimize gross contamination. But cleaning patient equipment isn't the only consideration. Also important is regular and routine cleaning and disinfection of environmental surfaces. Countertops, keyboards, and other horizontal surfaces should also be wiped down regularly. This includes those at front desk workstations. Spill kits are available in the team soil utility rooms, at reception desks, and in the lab. They contain instructions for biologic cleanup, personal protective equipment, absorbent and disinfecting agents, and biohazard bags. They should be restocked immediately following use. Only nursing, lab, and dental staff are permitted to clean biologic spills. Report bedbug sightings to your supervisor immediately. Fumigation is only ordered when bedbugs have been observed. Glove and collect a specimen if possible. This should be placed in a tightly sealed formalin jar and left in the affected room for the exterminator's inspection. Turn off exam room lights and seal lower door edges with table paper. Sign the room "Do Not Enter" with the date and time. Lobby videos may be reviewed to see if furniture was occupied. This should be placed in the room for fumigation also. Lobby chairs are heavy. Be sure to glove and ask for help with these. Doors should remain closed and articles left within following fumigation based on the exterminator's instructions. Viruses causing hepatitis B and C and HIV gain entry from contaminated Sharps injury, contact with mucous membranes, or through breaks in non-intact skin. Hepatitis B and C viruses target cells of the liver. Acute phase symptoms may include fever, fatigue, loss of appetite, nausea and vomiting, abdominal pain, dark urine, clay-colored stools, joint pain, or jaundice. Both hepatitis B and C may occur without symptoms, and while either disease may clear entirely, both have the potential to cause chronic infection capable of ongoing transmission to others. Chronic carriers are more likely to develop chronic liver disease, liver failure, or liver cancer. Hepatitis B and C may survive on contact surfaces for 7 and 4 days, respectively. Hepatitis B vaccine is provided at no cost to United Family Medicine employees. It is safe, effective, and can prevent infection even when given after exposure. There is currently no vaccine for hepatitis C, but combination antivirals have been effective in eliminating the virus or decreasing viral load. The human immunodeficiency virus attaches to and destroys a type of white blood cell, the CD4 T cell. As these are destroyed, certain infections and some cancers that would not affect healthy individuals emerge, a condition known as AIDS or acquired immune deficiency syndrome. Symptoms may include dry cough, severe unexplained fatigue, rapid weight loss, recurrent fever or night sweats, and swollen lymph glands. There is no cure for HIV, but antiretroviral drugs can decrease viral load to preserve immune function. Risk from any significant injury varies based on multiple factors. Overall risks are presented here from a single needle stick injury from an infected source. No risk is considered acceptable under OSHA's bloodborne pathogen standard. Even brief or seemingly inconsequential risk can result in disease transmission. While the vast majority do not, it is essential that you act. It's very important to excuse yourself and ask the patient to wait. In our experience, it can be difficult to get patients back for necessary blood work once they've left. Inform your manager immediately. They will engage the patient to have labs drawn. Act immediately also to cleanse the exposed area. For skin exposure, wash with soap and water a minimum 40 to 60 seconds. For eye or mucous membrane exposure, flush liberally with water and saline. As soon as you've cleansed the site, obtain a United Family Medicine Blood and Body Fluid Exposure Red folder. These can be found in all nursing team stations, the lab, and dentistry. Protocols included in the folder outline responsibilities for employees, managers, and the lab. Complete the employee report included in the folder. Answers from the report will determine whether yours was a significant injury and steps that must be taken. Call Employee Occupational Health Service at 651-241-5693. Be prepared to answer questions from your report. Employee Health will conduct a confidential medical evaluation. If the injury occurs after hours, follow instructions included in the red folder. This may include evaluation in the emergency department at United Hospital. Evaluation and treatment is confidential and available at no cost. Aseptic technique is followed when preparing and administering all medications and for sterile procedures. Procedures should be performed and potentially infectious materials handled so splash, spray, and spattering is minimized. Shoes covering the entire foot are required in areas where invasive procedures are performed, blood and body fluids are processed, or hazardous materials are used. Mouth pipetting or suctioning of any material, including blood, is strictly prohibited. Manufacturers of multi-dose vials are only required to demonstrate sterility for 28 days after first access. For this reason, vials should be dated with first use and discarded after 28 days. Vaccines are the exception to this rule. Multi-dose vaccine vials should not be discarded and may be used until labeled expiration dates. Any vial marked single use should be discarded after first use. Soiled linens are collected in appropriately labeled containers, taking care not to overfill. Laundry should be handled to prevent exposure and contamination of personal clothing and personal protective equipment worn when appropriate. United Family Medicine maintains a supply of disposable scrubs should your personal clothing become contaminated. These are located in the provider coat room. Food and drink may not be stored in or on cabinets, countertops, bench tops, shelves, refrigerators, or freezers in laboratory or clinical areas. Eating, drinking, applying cosmetics or lip balm, and handling contact lenses in patient care areas or where patient supplies are stored places both patients and staff at risk, so is also not allowed. And smoking is not allowed in any area of the building. We work best when we work together and value your input to identify disease transmission hazards and share ideas for safer work practices to prevent infection. Please share your thoughts with your supervisor or safety officer. You may also use safety hazard concern forms found in the employee break room and place these in the suggestion box for consideration. We appreciate all your efforts to protect our patients, our staff, and the greater community.
Infection prevention in a healthcare environment is critical. Healthcare-associated infections, or HAIs, affect one patient in every 20 admissions, kill 100,000 individuals a year, and cost $45 billion. One simple way to prevent the spread of organisms is to identify and control reservoirs. Staff and visitors should be healthy and not enter a patient's room if ill. Items brought into the room should be safe. Food and water should not be tainted. Equipment must be clean or sterile, and the environment should be sanitized on a regular basis. Controlling the mode of transmission is a little more complex, but with education and adherence to good practices, staff and visitors alike can help thwart the dissemination of pathogens. The CDC, NIOSH, the National Institute for Occupational Safety and Health, OSHA, and the Joint Commission are the main agencies overseeing the methods of infection control to protect patients, their visitors, and staff.
Educational video for healthcare workers on occupational health and infection control measures. Learning objectives. Review the occupational health and infection control principles. Identify the appropriate personal protective equipment to use based on the clinical assessment. Review how to put on and take off personal protective equipment safely. Recognize measures to prevent needle stick injuries. Video content. Hierarchy of control. Standard precautions. Use of personal protective equipment. Hand hygiene. Prevention of needle stick injuries. To protect workers against health hazards, we must apply the hierarchy of control. Based on this principle, first control at the source, control along the path, and only finally, control at the person. Control at the person is the focus of this module, and specifically, the correct use of personal protective equipment, PPE, including gloves, goggles, gowns, masks, surgical, or N95. Healthcare workers need to assess the risk of exposure based on the interventions performed, the patient, the type of working environment, and conditions. All those factors play an important role to determine the risk of exposure and the appropriate measures of prevention. Standard precautions include a series of measures to prevent direct contact with body fluids, blood, secretions, excretions, and minimize the spread of infection associated with healthcare. Healthcare workers need to apply standard precautions whenever providing care, despite the patient's diagnosis. Apply enough soap to cover all hand surfaces. Wet hands with water. Rub hands palm to palm. Right palm over left dorsum, with interlaced fingers and vice versa. Backs of fingers to opposing palms with fingers interlocked. Rotational rubbing of left palm clasped in right palm and vice versa. Rotational rubbing backwards and forwards with clasped fingers of right hand in left palm and vice versa. Rinse hands with water. Dry hands thoroughly with a single-use towel. Apply palmful of product in cupped hand, covering all surfaces. Rub hands palm to palm. Right palm over left dorsum with interlaced fingers and vice versa. Backs of fingers to opposing palms with fingers interlocked. Rotational rubbing of left thumb cupped in right palm and vice versa. Rotational rubbing backwards and forwards. Points to remember when performing hand hygiene. When hands are visibly dirty or contaminated with proteinaceous material, they should be washed with soap and water. If hands are not visibly soiled or contaminated, an alcohol-based hand product for routine decontamination of hands should be used. Ensure hands are dry before starting any activity. Personal protective equipment. Contact precautions. Gown, gloves. Some common respiratory pathogens, e.g. methicillin-resistant Staphylococcus, influenza, can be spread through the contamination of a patient's hands, the hands of a healthcare worker, or an environmental surface. Contact precautions should be applied whenever providing care to a patient suspected or known to have organisms spread by this route.
Miss Johnson, that's really the weekend. Oh, yes, I heard. What's wrong with her? She has fever.
I stayed home and rested all weekend because I know we have a tough week this week.
I just need some.
Just itch the most.
Just the hands and the back of the neck.
Okay, can I have a look at it?
Sure, you need to turn on the
Just turn the
side.
sheet down a little bit. Let me see what part of your hands.
Just right here.
Okay. It looks much better than it was yesterday. Right? So don't fall asleep until she comes back. All right. Take care. Bye.
Bye-bye. Thank you.
Use clean, unsterilized gloves and a disposable or reusable gown whenever you have direct contact with the patient. Remove safely the gloves and gown immediately following any contact with the patient. Perform hand hygiene immediately after removing any item of PPE. Dedicate specific equipment for use with a single patient and always clean and disinfect shared equipment between patient uses. Avoid touching your face, eyes, or mouth with either gloved or ungloved hands, as they may be contaminated. Place patients in a single occupancy room whenever possible, or alternatively with other patients with the same diagnosis. Droplet and contact precautions. Gown, gloves, medical mask, or surgical mask. Droplet and contact precautions. Diseases which are spread via droplets can be transmitted by an infected person when talking, coughing, or sneezing. For example, adenovirus human influenza. Typically, droplets travel only a short distance through the air, but have the potential to land in the eyes, mouth, or nose of an unprotected person or an environmental surface. Droplets do not stay suspended in the air.
Wait, don't go in there. You need to put on your PPE first before you enter. This patient is an isolated room. So your stethoscope and the chart could be left outside the room. Next, we're going to use a mask. Now this patient, she has the flu, but she's getting better. And she took it to more than others.
Why do we need the eye protection?
Well, it would give us protection just in case she coughs. So it will be a shield from material getting on us or in our eyes. You know, some people use goggles too. Okay. Right, you make sure the glove goes over your cough. Because of course in front of the shield could be potentially could be contaminated.
Droplet precaution guidelines. Wear a medical mask when within a 1 meter range of the patient. Put the patient in a single room or in a room that contains only other patients with the same diagnosis or with similar risk factors, and ensure that every patient is separated by at least 1 meter. Ensure that the transportation of a patient to areas outside of the designated room is kept to a minimum. Perform hand hygiene immediately after removing any item of PPE. Use clean, unsterilized gloves and a disposable or reusable gown whenever you have direct contact with a patient. Remove safely the gloves and gown immediately following any contact with a patient. Perform hand hygiene immediately after removing any item of PPE. Dedicate specific equipment for use with a single patient, and always clean and disinfect shared equipment between patient uses. Avoid touching your face, eyes, or mouth with either gloved or ungloved hands, as they may be contaminated. Place patients in a single occupancy room whenever possible, or alternatively with other patients with the same diagnosis. Personal protective equipment, droplet precautions, medical mask or surgical mask. Droplet precautions. Diseases which are spread via droplets can be transmitted by an infected person when talking, coughing, or sneezing. For example, adenovirus human influenza. Typically, droplets travel only a short distance through the air, but have the potential to land in the eyes, mouth, or nose of an unprotected person or an environmental surface. Droplets do not stay suspended in the air. Wear a medical mask when within a 1 meter range of the patient. Put the patient in a single room or in a room that contains only other patients with the same diagnosis or with similar risk factors, and ensure that every patient is separated by at least 1 meter. Ensure that the transportation of a patient to areas outside of the designated room is kept to a minimum. Perform hand hygiene immediately after removing any item of PPE. Pathogens transmitted through inhalation of droplet nuclei can remain infectious over a long distance, more than 1 meter. Diseases such as pulmonary tuberculosis, measles, and chickenpox are transmitted via this route. Airborne precautions should be applied until the mode of transmission is confirmed when dealing with a novel or unknown pathogen.
Right. It goes like this, right? And you have it hooked in the hand like this with the straps loose over the hand like that. Then you bring it up to the nose. Chin first, and then cover the nose. Upper band, and you put reaching up on the top of the head. Then you use other band, reaching below the ears. Okay. Then you use both hands to get a seal. Exhale and see if you feel any air coming out from the respirator. Hi, Mrs. Rodriguez. We're here to pay your visit. This is my intern.
Hello, good afternoon, Mrs. Rodriguez. How are you feeling this afternoon?
Come out to the room. We need to do hand hygiene.
Use a particulate respirator whenever entering and providing care within the patient isolation facilities, ensuring that the seal of the respirator is checked before every use. Place the patient in an airborne precaution room, which has 12 air changes per hour, plus control of airflow direction. Limit the movement of the patient and ensure that the patient wears a medical mask if outside their room. Perform hand hygiene immediately after removing any item of PPE. Personal protective equipment. Never recap used needles. Never direct the point of the needle to any part of the body except prior to injection. Do not remove used needles from disposable syringes by hand, and do not bend, break, or otherwise manipulate. Dispose of syringes, needles, scalpel blades, and other sharp items in appropriate puncture-resistant containers, which should be located as close as practical to the area in which the items were used. Avoid the use of reusable syringes. Do not reuse needles. We would like to thank the volunteers who have offered their time and expertise to produce this video on occupational health and infection control in healthcare settings. Special thanks to the Ministry of Health from Trinidad and Tobago, Government of Canada, University of British Columbia, British Columbia Centre for Disease Control, and Vancouver Coastal Health for their support of this video.